Welcome everyone to VisionCorps Presents our Macular Degeneration presentation today. I'm going to review a few things here and then we'll get jumping right into the presentation. So again, welcome. We are asking that everyone keep all of their mics on mute. We will be recording this presentation. That way folks who couldn't join us today could certainly catch it, or if you'd like to hear it again. We ask that if you're able to turn off your camera, that would be great as well. Following the presentation, we will have some time for some questions and answers. Although we won't have time to get to all of them, we do think this will be a really good part of the presentation as well. So after the presentation, again, I'll start the question and answer session and I can let you all know how to do that at that time. So before we jump into the presentation with Dr. Gewaily, I just wanted to quickly welcome all of you who are VisionCorps clients, and also welcome those with us who are not yet working with us here at VisionCorps. VisionCorps is a rehabilitation services agency serving folks of all ages in 5 different counties: Lancaster, Lebanon, Chester, York, and Adams. We have been around for over 90 years. I'm just going to touch briefly on the services we have for adults. In addition to offering educational presentations like this one, we're happy to offer a lot of other services to assist individuals with vision loss or blindness to be as independent as possible and to have the highest quality of life. So that might involve working with our low vision occupational therapist on daily living skills and activities. It might involve working with our technology specialists as well. We know technology is a big part of everyone's life, but if you're not a big user of technology, it might be something to start, because technology can really be a big help for those who are vision impaired or blind, again, to stay connected and stay independent with things that might be challenging now. We also have orientation and mobility specialists, which can assist individuals to stay independent and safe when they're out traveling, whether that be to the mailbox or, on a train or on a plane, on a bus and everything in between. Again, to not keep folks isolated or afraid to leave their homes with that new vision loss or blindness. And we also have a number of opportunities where you can connect with your peers with our virtual and in-person support groups. So again, I'd love to talk with any of you about how to get connected with us at VisionCorps. It's a very simple process, and you certainly can reach back out to me on how to do that, and then I can get you connected with the case manager in your county. So I'm going to introduce our wonderful speaker. Dr. Dina Gewaily is an experienced retinal surgeon at Lancaster Retina Specialist. She completed her ophthalmology residency at the University of Pennsylvania's prestigious Shea Eye Institute. At Penn, she was a member of the surgical retina team that developed the first FDA-approved gene therapy in the United States for an inherited disease. And I know I can go on and on, but I'm definitely going to turn it over to her, because I know that's who we are here to listen to. So I'll turn it over to you.
Okay, thank you very much, Ms. Greth. Can everyone hear me? Okay,
Yes.
perfect. Okay, great. Thank you so much for having me, and thank you all for taking the time out of your Monday morning to listen to this talk. Of course, I greatly appreciate everything that VisionCorps does for our patients, and they have nothing but amazing things to say. So thank you very much for all of your work. So I'm here to spend some time talking about age-related macular disease or degeneration, which I know is very overwhelming and can be a pretty anxiety-provoking topic. And I really commend all of you for taking time out of your schedule to learn more about the disease, because I truly believe that the more you know about AMD, for short, the better off you'll be. So. I want to focus on specifically age-related macular degeneration. There's lots of different types of macular degeneration, but we'll specifically focus on the most common type, which is the age-related. So AMD, which is age-related macular degeneration for short. So I'll just say AMD from now on, affects the retina. So the retina is the back lining of the eye. I think of it as the film of the camera. And it's important that the retina functions well in order to see well. AMD specifically affects the macula. So the macula is specifically the center of the retina. So we're talking about an age-related disease that affects the center of the retina. And it is the most common cause of vision loss in those over the age of 50. So if you look at the numbers, Americans ages 65 and up will have 1% of the population affected by AMD. So 1 out of 100 people age 65 and up in the United States have some form of AMD. That number goes up significantly, as you can imagine, the older the individual is. So by age 80, 12% of Americans have some form of AMD. 12 out of 100. So, with people living longer, this disease is becoming more and more prevalent. So, there's a lot of work being put into this disease, and I'm going to go into the treatments in the second part of the talk. There's two types of age-related macular disease or AMD. There's the dry form and then there's the wet form. The most common form is the dry. So the dry affects 80 to 90% of individuals. So most people will have dry. 10 to 20% have wet AMD. And pretty much everyone who has wet starts off with dry. So dry is the beginning stage. In the dry form of AMD, what happens is that the macula or the center of the retina becomes thinner with age. And waste deposits, which we call drusen, start to accumulate under the retina, and then that affects vision. What defines the wet form of the disease is when there is a breakdown between the layer of the retina and the layer beneath the retina, which has lots of blood vessels. So once you have a breakdown of that blood retina barrier, fluid starts to seep under the retina and within the retina, and that can affect vision. So the retina should be nice and dry in order to see well. But if you have fluid or blood or cholesterol leaking in or underneath the macula, that would affect the vision. And we do have lots of treatments for the wet AMD, which I'll go into. What I get asked a lot is what's better to have, dry or wet? Um, Unfortunately, of course, we don't have control over whether an individual will stay dry or convert to wet. But my answer to that question is an early case of wet caught early and treated promptly is usually better than an advanced case of dry. So it really depends because there's early, intermediate, middle, or late advanced stages of dry, and then there's early, or advanced stages of wet. So it really depends on the case. Okay, so that's my brief introduction into AMD. So what are the risk factors for AMD? Some risk factors we can control, other risk factors we can't control. So it's important to know, of course, what risk factors we can control so that we could slow down or limit the progression of the AMD. So, of course, age, it's in the name of the disease. Unfortunately, no one's figured out a way to change age. We can't modify that. So that is the biggest risk factor as I had mentioned. So the older you are, the more likely you are to develop AMD. Genetics is something else we can't control. So AMD tends to run in families. It's not 100% guaranteed that you will get AMD if your parents or siblings have it, but it becomes a little more likely. There is no specific AMD gene. So we can't run genetic testing and say, oh, you're positive for AMD, you're going to get AMD. We don't have that sort of testing at this point. And there's over 30 genes that have been implicated to potentially contribute to AMD. So again, this is being studied in the field. At this time, the American Academy of Ophthalmology does not recommend routinely studying, testing for AMD genes in the office. So it's still being studied. So we talked about age, we talked about genetics. These are two things we can't control. However, we can control our smoking status. So probably the biggest modifiable risk factor for AMD progression is whether or not you're a current smoker. So, smokers and ex smokers are not only more likely to develop AMD, but they're also more likely to have worse AMD. So, probably the best thing to do would be to avoid both cigarette smoking or secondhand smoke. And what smoking does is it just increases inflammation in your body, including in your retina, and it probably contributes in more waste products being deposited under the retina. Another thing that we have some control over is our diet and our lifestyle. So, studies show that obesity and an inactive lifestyle can make AMD worse. And it probably it has to do with the same thing, which is inflammation in our body. So, obesity can increase the inflammation in our body, and that includes in the retina. So it's important that we have an active lifestyle and work on diet. And I'm also going to talk about what the recommended diet is to slow down AMD in the treatment section. Other risk factors for AMD would be heart disease, high cholesterol, and high blood pressure. So, again, we have that layer under the retina, which consists of blood vessels. So, if the blood pressure is very high or if there's very high cholesterol within those blood vessels, you may develop more deposits under the retina and make the disease worse. So, again, of course, we don't have complete control over our heart disease or high blood pressure, but we have some control. So, it is important to try to focus on that with the family doctor. Caucasian race is associated with AMD. And the role of sunlight exposure is a little unclear. So I always tell patients it's probably good to have a nice pair of sunglasses uh, just for your comfort and also to possibly slow the AMD down. Okay, so those are the risk factors for AMD, and that applies to both the dry and the wet. Okay. Moving on, let's talk about symptoms of AMD. So, the macula, which is affected in AMD, is the center of the retina, and correspondingly, it affects your central vision. So, when you have disease of the macula, you're going to generally have problems with your central vision. The early stages of AMD tend to present as problems with contrast
Hello.
or hello. Okay. The early stages of AMD can present as problems with contrast sensitivity. So you may find that you're needing to use more light to perform tasks that you didn't need as much light for, such as reading in particular. And then as the disease becomes more advanced, and that's whether it's dry or wet, you could then have problems with your central vision, including blind spots. And really, you have to close each eye separately to really appreciate if there's a change, because really good vision in one eye can mask a problem in the other eye. And I'll go over that some more when we get to the monitoring and testing of AMD. But for instance, if your central vision is affected, you may be looking at a clock and you might not be able to see the hands of the clock, but you could see the numbers of the clock. So it's the center of objects. Or if you're looking at someone, you may have trouble seeing their eyes and nose, but you see their hair. The good thing is, and what I always try to reassure my patients, is that it's very rare to also lose your peripheral vision to AMD. So naturally, patients are very upset because the center vision is important. But you should never get to the point where things go completely dark. I have only a handful of patients who are at that stage, and they usually presented to the office that way. And it's because things just went unchecked for a very long time, or they happen to have a very aggressive form of AMD. But for the most part, almost all patients will always maintain their peripheral vision. Unless, of course, there's another eye problem on top of the AMD. So that should provide some people with some level of reassurance. And the biggest thing is to really go for regular eye exams. So, really, anyone over the age of 65 should be getting an eye exam with either an optometrist or an ophthalmologist every 1 to 2 years at the minimum, even if there's no diagnosed problems. So, and the reason is sometimes a physician can pick up an early form of AMD, and the more you know about your health, the more in control you are, and the more um, you will know what to look out for and when to seek prompt attention. So I see a lot of patients who, unfortunately, their one eye will be lost to AMD because they have gradual blurred vision that he or she attributes to a cataract or a more benign cause, and then it turns out it's scar formation from AMD. So key is really to stay on top of your health, and 65 and up, go for regular eye exams. Okay, so uh, something else to note with AMD is the dry form tends to be more gradual in progression. Um, but up until last year, we really didn't have much to offer dry AMD patients. I will go into the treatment of dry AMD in the last section. The wet form can come on a little more suddenly. So it's important, if you don't have an Amsler grid, AMSLER, an Amsler grid at home, that you get one. It's very easy to obtain online or from VisionCorps or from your eye doctor. And what I advise people to do is just keep it on your refrigerator, because we always remember to go to our refrigerator. And you test your eye by test your vision by covering each eye separately, and there's a black dot in the center, and there's grid with lines that should be straight up and down. And the moment you start to notice a wave in the line or a blind spot, that's when you want to seek medical attention. And you would hold that grid in a well lit environment with your reading glasses on, and again test each eye separately, holding it at about reading distance. Okay, so that's the symptoms of AMD. So we covered the wet, the dry, and the symptoms across the different stages of AMD. Okay, so how do we diagnose AMD in the office? So we have lots of ways of diagnosing AMD. It tends to be a pretty straightforward diagnosis. And the first thing we would do is perform an exam. So we dilate the eyes. We can't get a good exam without putting the dilating drops in, and then you would sit in the office for about 20 to 30 minutes. The pupils get nice and big, and then we put on a headset and take a look at your retina. And also, we look at the microscope. So that's the most basic way to examine. However, we also rely on lots of imaging modalities, and we're very lucky to have very good technology and ways to pick up very early signs of both dry and wet AMD, sometimes before the patient even experiences any symptoms. So, the most basic test that we perform is something called an OCT, which stands for optical coherence tomography. It's a non invasive test. It takes just a few minutes. You put your chin on a chin rest, and we image each eye separately. And what that is showing us a cross section of the macula, or the center of the retina. And we can see the deposits under the retina in the dry form of AMD. We can see fluid under the retina or in the retina, and that would be an indication to treat. So, pretty much everyone who walks into a retina office is going to obtain an OCT. It's one of our most basic testing modalities. Some physicians like to obtain something called an intravenous fluorescein angiogram. Some routinely, or others if we're trying to decide if it's a case of early wet AMD. And that's about a 5-minute test that we perform in the office. We inject some dye in the arm. It's not contrast dye, it's something called fluorescein dye. And then we take pictures for about 5 minutes. of both eyes. And that will sometimes give us very useful information. It tells us about the blood flow in the retina. And if there's some leakage on the dye test, that is potentially a sign of the wet AMD as opposed to the dry AMD. And that could sometimes determine our treatment. It's a test we would not do in case of pregnancy or if someone has a documented allergy to the fluorescein. It's pretty safe at tests. However, 10% of people might experience a little bit of nausea with the test that passes once the dye has passed. Um, and it's interesting, your skin and urine will actually be a little orange for 1 to 2 days, and that's completely normal. And that's a result of the dye going through your body. Very, very rarely, 1 out of 100,000 would have a severe allergic reaction to the fluorescein, but that's 1 out of 100,000 people. Other tests that we would do in the office potentially is something called an OCTA or angiography, which is non invasive using the same machine as the OCT. And there are some issues with that test and still has some artifacts. So it's not something we do on a very routine basis, but that is something else that we do. Very rarely would we have to do something called an ICG, which is similar to the fluorescein angiogram, but using a different type of dye, and it's a 15-minute test. I don't remember the last time I've ordered an ICG in diagnosing AMD, but that is another potential testing modality. And really, the Amsler grid is pretty important because sometimes the patient is convincingly having new symptoms, specifically a symptom we call metamorphopsia, which is wavy lines, so lines that are straight appear wavy. And if I don't see a very convincing case of wet AMD, but a patient is very convinced they're having new onset wavy lines, that may also determine the way we treat the patient. So, lots of things that go into it, but it's a pretty straightforward diagnosis. And as I said, a pretty common disease in the elderly, which we see a lot of in our practice. Okay. So now let's talk about treatment. This is best divided into treatment for the wet AMD and a treatment for the dry AMD because they are treated quite differently. So wet AMD is something that keeps us very busy in Lancaster Retina. We have a lot of patients with wet AMD that require injections. So before injections were developed, all that was available was laser, and there was the thermal laser in which we would just ablate blood vessels. Now, this is a pretty destructive procedure, and it's definitely been replaced by the injections because it does not perform as well as the injections. There's also a different type of laser called the PDT laser or photodynamic therapy. Again, not something we do commonly for AMD ever since the injections came out. So, and I'll go into that in a moment. But PDT sometimes stabilize vision, but a lot of people could have worse vision because back in the day they were using the full fluence or full strength PDT. Now we typically use half strength with much fewer complications, but it's inconvenient. It's a long procedure. You'd have to avoid sunlight for 4 days, and it did not improve vision the way the injections do. So sometimes I do get asked in the office, isn't there a laser you can do? Because naturally, the idea of getting shots in the eyes can be pretty anxiety provoking, but really the shots are the main treatment modality at this time. So speaking of injections, Avastin, which is the most common injection we give, has been around since 2005. So it's been around for decades. It's a safe treatment and it's very effective treatment. And in the past couple days, years, not days, years, we've had more injections be approved for AMD, which is very exciting. And I'll list all those for you in a moment. What all these injections do is lower a specific hormone in the eye. It's called VEGF. It's a mouthful. It stands for vascular endothelial growth factor, VEGF. Now, some VEGF is normal in the eye. It's produced in all of our eyes and it helps blood vessels function properly. However, in eyes with AMD, and specifically wet form of AMD, the VEGF levels are too high. And that's what's causing abnormal blood vessels to grow and break through the retina and leak. And that's what causes the wavy lines and the blurred vision. And if left untreated, can even form scarring in or under the retina. So, what all of the injections on the market for wet AMD do is lower the VEGF hormones. And there's one injection, the newest on one of the newer ones on the market called Vabysmo, which blocks another pathway as well. So the very first injection approved is a drug called Macugen, and that is now off the market because it doesn't work as well as the others. So then the second one to come was is the Avastin, which interestingly enough is actually a chemotherapeutic agent that we inject in the eye. It was discovered to work very well in treating a variety of retinal diseases, not just AMD, but we give this for diabetics and people with other retinal problems, and it works very well. Interestingly, it's off label, so it has not been approved by the FDA specifically for the eye, but it is still the most common injection retina specialists across America give, and it is very effective and safe. So, in addition to Avastin, there's also a drug called Lucentis and Eylea. Beovu came out a little before the pandemic. Vabysmo, which we get a lot of questions about because there's a lot of commercials on Vabysmo and how it potentially lasts 4 months. And then the newest to be approved for wet AMD is actually high dose Eylea. So we've had Eylea for years and years and years, and now they came up with another formulation of Eylea in which it's 4 times the strength as the one we had before, and they all work quite well. They're one of the drugs, the Beovu, is somewhat associated with bad inflammation, extremely rare. Um, uh, and all of the drugs actually can cause inflammation at different rates, but we may give a little less Beovu as a result. Also on the market in the last couple of years are what we call the biosimilars, and they're drugs that are similar to what's already been approved, specifically Lucentis, but they're a little bit different in their structure. And some insurances will have us use the biosimilars before we move on to the other medications. And two of those drugs now on the market are called Cimerli and BioViz. There will be more than likely biosimilars for Eylea, but they're not yet approved. So we have the Avastin, Lucentis, Eylea, Beovu, Vabysmo, and high-dose Eylea. You may wonder, well, how do we decide which drug to give? It's actually really good that we have so many options now. We'll often start with Avastin, and then if that does not work or doesn't last as long as we want, we may switch to other medications. A patient's insurance company may also dictate what drug we start off with. However, a very big study that came out of UPenn was a head-to-head study comparing Avastin, Lucentis, and Eylea, showed that really all three drugs are equivalent in safety and efficacy. The big issue really is just the durability of the drugs, and this is a big field of research within the retina field, and just trying to because the drugs work well. It's just they don't work as long as patients would like them to work. So for some people, they can, he or she can go out 16 weeks in between shots, but some people need the injections every 4 weeks, and it really depends. It's a case by case basis. So the biggest thing, and I'll delve into it a little bit more in the treatment section towards the end, the experimental treatments is really coming up with longer acting VEGF inhibitors to treat wet AMD. In my hands, really the biggest predictor for success and going longer in between your shots is to catch things early. So I find that if I have a patient who gets started on wet AMD treatment before he or she's even symptomatic, they tend to hold on to good vision for a much longer period of time and can go a longer time in between injections. So just something to keep in mind. I get asked a lot, is there a cure for AMD? And I do try to emphasize to patients from the very first visit that this is a chronic condition at this point. No one has come up with a cure. It's sort of analogous to asking, is there a cure for aging? This is a condition of aging of the retina. So, is at this point, there's no cure. We just want to control it as best we can, maintain good vision for as long as we can, and hopefully with a few injections as possible. But once an individual is diagnosed with wet AMD, really it becomes imperative that he or she continues with close follow ups. Now, when we talk about treatment for wet AMD, there's the induction phase of the treatment, and then there's maintenance. Induction is when we're trying to pretty aggressively dry out the retina, stabilize things, get the best vision possible. And generally, in the induction phase, we're giving injections every 4 weeks until we can dry out the retina. Once we've reached that phase in which we've stabilized things as much as possible, then we shift over to maintenance phase of treatment. Now, there's different ways to go about the maintenance. Um, I would say the majority of retina specialists will then start what we call a treat and extend protocol, which means that you get an injection every time you come to the office, but the injections are spaced out more and more so long as the disease is stable. So basically, we would start off with giving a shot every 6 weeks. If the individual comes back at 6 weeks and the OCT shows a dry macula, there's no bleeding or cholesterol in the eye, and the vision is stable, then we would tell the patient, okay, you'll get a shot this time, and then we'll extend you out to 7 weeks. Do that a couple times. Okay, you're stable. We will now try 8 weeks. However, if we get to the point where we extend, let's say for 10 weeks, and then we see a pocket of fluid on the OCT or a vision change, then we know 10 weeks at this point is too long for the patient, and we cut back to 8 or 9 weeks, for instance. The whole point is to maintain the vision and keep things as stable as possible. But that doesn't mean that individual will be stuck at 8 week shots for the rest of his or her life. So it is possible that in a year or so, we say, okay, you've been stable for a very long time at the 8 week interval. Let's now try 9 weeks. And it's a constant trial and error in a safe and controlled way to try to, again, to get the best outcomes with as few shots as possible. Now, that's the treat and extend protocol for wet AMD. We could also do something called treat as needed. Now, treat as needed would give you the same outcomes, it should, with generally the same number of shots. However, it's a different management style where in which the patient would come to our office at the beginning every 4 to 6 weeks, but only get an injection as needed. I like treat as needed for patients who have wet AMD in both eyes because basically the patient would come. If the right eye needs a shot, the right eye would get a shot. If the left needs a shot, the left. If neither needs a shot, no shots administered. If both need a shot, both get injected. It just, so it means we touch base pretty often, but the patient does not necessarily get an injection every visit. And it can make things a little less complicated than if you're doing treat and extend and one eye is in one interval, the other eye's at another interval. But really, I do my best to tailor the treatment to the patient because there's a lot of things to consider outside of just the retina itself. We have patients; most of them rely on transportation. They have drivers. I take into account how far the patient lives from the office, whether or not he or she can tolerate injections in both eyes at the same time. So we really have a long discussion with the patient and try to figure out what's most comfortable and makes the most sense for the patient. But the point is, there's different ways to go about it. With some patients who have had a very bad case of wet AMD in one eye, we may opt to just regularly treat the other eye because we don't want any chance of of a bad scar in that eye. So I do have patients who say, "Listen, I want a shot every 6 weeks, regardless, or every 8 weeks, regardless." I also take into account if there's recurrences of blood in or under the retina. If the patient's on blood thinners, he or she may be more likely to get scarring. Now we never stop blood thinners in the treatment of wet AMD because we assume that the patient needs to be on blood thinners for very important reason, like stroke prevention or something like that. So we don't stop the blood thinners, but we would just take that into account when managing the wet AMD. Okay, so that's pretty much what I have on wet AMD treatments or what's currently available. I figured I would spend a little bit of time talking about the injection procedure itself because patients obviously have a lot of questions if he or she has never had shots before. And I just wanted to get rid of some of the mysteries so that patients wouldn't be as anxious about injections. Now, it's really not as bad as it seems. And oftentimes, when I finish the injection, patients will say, "Oh, well, that wasn't bad at all," or they'll tell me, they may have had shots for years and years, and they may say, "Listen, it's really the thought of the injection that bothers me more than the shot itself." We have lots of ways to numb the eye and make the actual procedure as comfortable as possible. So I have a default way of performing the injection, and then I often will make adjustments based on the patient feedback the following month. But basically, what's involved is we first numb the eye very well. And that will typically involve a combination of lots of numbing drops, followed by a possible numbing injection if the patient prefers. And then what happens is we clean the eye. So the way the eye is cleaned is with betadine. Betadine is probably, to be honest, the worst part about the procedure, but it's just an eye drop. But what betadine does is it can sting a little bit, but that's important to clean all the bacteria on the surface of the eye. So betadine is what prevents a potentially blinding infection in the eye. Once we have the betadine sitting on the eye surface, prior to that, we'll actually typically use a speculum to prop the eyelids apart. That's a very good way of keeping the eyelashes out of the way because the eyelashes have a lot of bacteria and we don't want the bacteria anywhere near the injection. So the eye is numb. We have an eyelid holder or a speculum keeping the eyelids apart. We put the betadine on the eye surface. That betadine sits on the surface for at least 30 seconds. So it's a little bit awkward because it's silent and we're just looking at each other for 30 seconds. But that part's very important in order to clean the eye off completely. And then we go in with a really small needle, few seconds in and out, and it's over. And really, patients do not feel anything sharp if done properly. And then we rinse the eye out with sterile saline. It's not water. You never want to put water in the eye for the first 2 days after the injection. It's a saline solution to clean out the betadine. And then after that, it depends on what the patient prefers. So we'll sometimes put a strip of ointment in the eye, sometimes just some tears, sometimes a patient may want to be patched. So again, this is where we sort of tailor the injection procedure to the patient, but that's the general gist of it. Miss Grath, are we still good on time? How much longer would you?
Yes, we are. We have
Okay.
this presentation until noon. So,
Okay.
much would you like to go? And then we'll have some little bit of questions and answers if we can fit that in.
Okay, perfect. I just don't want people. Okay, sounds good.
You're good. You're the star.
All
We're here for
right, all
you.
right. I don't want to bore anyone.
Thank
Okay,
you.
sounds good. All right. So that's generally the injection procedure. Now, I am pretty strict with my patients when I do the injection. I always ask the patient not to talk. Now, that sort of sounds rude, but I try to say it in a nice way. There's a very specific reason why I'd say that, because we don't want the mouth bacteria entering the eye. Studies have showed that talking during an injection is a risk factor for something called endophthalmitis, which could be a very serious blinding infection, which we always want to avoid. So no talking during the injection, and also you try not to move your eye around too much so that the eye stays clean, and we put the needle in safely and come out. So um, there are risks to the injection. Really, the biggest thing people will experience is some irritation for a day, maximum 2 days. And that irritation is in the form of foreign body sensation, and that's from the antiseptic, the betadine. The best way, really, to tackle that problem is to use frequent artificial tears. We advise now patients to stick to the brand name tears because of some issues with some brands causing potentially blindness or serious issues. So we generally will provide the patient with a list of recommended artificial tears, and you just continue that for a day or two, and that takes care of most cases of irritation. Basically, things should never be getting worse. They should get better. So the irritation should be gone by a day. Sometimes the patients will experience a red eye after the injection. So it looks bloodshot, and that's pretty startling at first for patients, especially if you don't expect it or you don't know what's going on. But if the eye looks bloodshot after an injection, it's really typically just a bruise. There are lots of blood vessels on the surface of the eye, and that typically will go away in a couple days, week, maximum 2 weeks. Now, if a patient is on blood thinners at baseline or even an aspirin, he or she is going to be a little more likely to develop this bloodshot eye, and there are ways to decrease the occurrence, but again, that tends to be just a cosmetic thing. More serious complications are fortunately very rare. So the endophthalmitis, or the infection after an injection, fortunately only occurs in 3 out of 10,000 injections. So it's very rare. Bleeding into the eye is also not very common and generally will clear. There's always a very, very small risk of a tear in the retina. So I always give my patients what we call retinal detachment precautions, which pretty much means if there's an increase in floaters or flashes, that we should know about it. Now, right after the injection, it is common to have floaters for about 2 days, and that comes from the bubbles in the syringe. So sometimes not all the bubbles get cleared from the syringe or the needle, and you'll see these perfect circles for about 24 to 48 hours, which should then disappear. Those are just air bubbles, and they're completely benign. There are cases of inflammation which can be mild to serious, and also tend to be quite rare. It's all about really seeking attention if you think you're having any unusual reaction. So that's pretty much what I have for treatment of wet macular degeneration, or wet AMD. So let's move on to dry AMD treatments. So this is pretty interesting topic now, because up until 2023 or last year, we really had absolutely nothing to offer patients in terms of medications other than the eye vitamins, which I'll go into. But last year, two drugs were approved for the treatment of dry AMD. So let's start off first with the basic treatment. So the AREDS 2 vitamin is something that we recommend for people with the intermediate or middle stage dry AMD. This is a vitamin that is found over the counter. Some common brands would be Preservision or Ocuvite, although there's definitely more brands out there. The key is really that it has the word AREDS 2 on it, so AREDS2. And what the AREDS2 vitamins contain are certain minerals. So specifically, it is 500 milligrams of vitamin C, 400 IU or international units of vitamin E, 10 milligrams of lutein, 2 milligrams of zeaxanthin, 80 milligrams of zinc oxide, and 2 milligrams of copper oxide. So basically, a big study called the ARED study showed that this vitamin formulation may slow down the progression of the dry AMD. And I do have patients who will get started on it even if they have the early form of dry AMD, and I don't stop them from taking it. But it's not generally indicated for everyone out there to prevent AMD. That hasn't been studied. Um, but again, it's over the counter. The side effects, the most common would be stomach upset. So if I have a patient who complains of stomach upset, I'll generally advise him or her to try a different formulation or a different brand, or perhaps it comes in powder form, chewable form. And if really then he or she can't tolerate it, I say, you know what, that's fine. It's a vitamin after all, it's not a cure. And it was really studied in one big study, but we don't have lots and lots of studies on it. So it's just one out of several things that we could try to do for the dry AMD. And of course, with anything, any vitamin, any diet, any exercise regimen, you want to run things by your PCP, just to make sure that he or she clears you for it. And the AREDS2 vitamin would be in addition to whatever typical multivitamin the patient takes. Now, we mentioned how obesity and poor diet can be a risk factor for AMD progression. So, what is the diet generally recommended for AMD? And it's the Mediterranean diet. So, I advise patients to try to include a lot of vegetables in their diet. Specifically, green leafy vegetables are known to be good for the retina, but again, run it by your PCP, because if you're on a blood thinner such as Coumadin, there's some interactions and things like that. But assuming it's cleared by the PCP, you want to have green, red, yellow vegetables in your diet. Kale and spinach are very good. If you like fish, having fish twice a week is also thought to be good for the retina. Having healthy fats in the diet, eating nuts. If possible, try to avoid a lot of red meat, which may increase what we call oxidation of the retina or further aging damage. Generally, we say it's good to try to obtain your nutrients from the diet rather than to overdose on supplements. So, you generally, just because the AREDS2 has these certain components in it, don't think that if you triple the amount of vitamin C you take by mouth or vitamin E that you're going to be better off. That has not been shown to be the case, and it might not be good for you. Okay. So, also, in order to avoid the progression of AMD, we discussed the importance of smoking avoidance. It's probably the single and most important modifiable risk factor that we have. Regular exercise and maintaining a good weight. So, again, depending on your physical activity level, generally 30 minutes a day, 5 days a week of physical exertion is going to help decrease the inflammation in your body and the retinal damage. And the important thing is, as mentioned before, regular follow up. So 65 and up, you're going for at least your annual eye exams at a minimum. But I generally follow most dry AMD patients twice a year, every 6 months, because I feel if the dry AMD switches over to wet, I would rather catch it within a couple of months rather than wait a full 11 or 12 months to treat it. Because again, the longer wet AMD festers, generally the more scarring a patient can get or irreversible vision damage. So I'll do twice a year. For people who are really high risk dry AMD, I might even follow them quarterly or come up with a schedule in conjunction with the regular eye doctor to maintain a good follow up. Okay, so finally, I can actually discuss two injections for dry AMD that were approved last year. The two drugs are called Syfovre and Izervay. So at this point, we're offering Syfovre in the office. Izervay, because it's been less than 6 months, I'm pretty sure, of approval, is still not getting reimbursed by the insurance, and it's a newer drug. Um, Syfovre is interesting, as is Izervay. I've been in the field of ophthalmology since 2010, and as far as I'm concerned, I have not seen a topic more debated amongst retina specialists than the dry AMD drugs. So, really, the field is still quite split over how effective, how useful these drugs are. Some people are huge proponents of it and say, listen, we right now don't have a treatment or a medication to offer dry AMD patients. And this is a huge step in our field. And it's something we could offer patients because the end stage of dry AMD, which is called geographic atrophy meaning loss of retinal tissue or progressive thinning, as I discussed, is is progressive and it's irreversible. So if we have something to offer patients, that's an amazing step forward. However, due to the fact that these drugs at the 3-year mark have not been shown to improve vision, some retina specialists will say, well, why would we give a drug, inject a patient every 2 months or every month if at 3 years this patient will not have improved vision compared to those who are not getting the shots? And that is what the most recent data has showed for Syfovre. And that is a valid point, of course. However, no one knows at this point the data for 4, 5, 6 years and beyond. So it is a very debated topic. I've been to several conferences in the last few months, and it's still the same thing. No clear consensus on these injections. The injections are given, they're FDA approved to be administered every 28 to 60 days. I generally am doing the every 60-day protocol or every other month because the data has showed that the every other month has 80% the efficacy. And by efficacy, I mean slowing down the atrophy progression. So, again, no impact on vision, it just slows things down. 80% efficacy with half of the side effects. So I am right now doing every other month. Again, for those who want it, I generally don't push at this point Syfovre on a patient. No, push is not the wrong word. I don't strongly emphasize the importance of Syfovre. I present the data and then I let the patient decide. So there are risks to the Syfovre and the eye. Specifically, we'll talk about Syfovre. The risks are the risks that come with any other injection that I discussed, which is a very rare risk of infection, which could be potentially blinding, inflammation, a little irritation, red eye, retinal tear detachment. The really bad risks are very rare, fortunately. However, specific to Syfovre is a little bit elevated risk of converting to wet AMD. So again, the Syfovre is to treat dry AMD to slow the progression down. But what the studies found, for unclear reason, is that there's a 7% risk of converting a patient from dry to wet AMD on Syfovre compared to only a 3% risk for someone who does not get the Syfovre. And then what we'd be looking at are shots for the dry AMD component and then the wet AMD component. And we typically don't do that in the same visit because it's just too much drug to inject in the eye at once. So then a patient would potentially be looking at coming in every single month for shots. So that is something to consider, of course. Some retina specialists are not bothered by this risk because they say, well, we have very good treatment for wet AMD. So even if wet AMD develops in a patient getting Syfovre for dry, we have treatment for it. We don't have treatment for the dry. If we let it go, it's just going to get worse. So again, a little bit of debate about that. Also with Syfovre is a very small risk of a permanent stroke to the nerve. So that risk is thought to be 0.2%. So 1/5 of 1%, 1/5 of 1 out of 100. And that would be a permanent stroke to the nerve. Again, no one really knows exactly why that happens. And then a few concerning cases of a really bad inflammation that could cause irreversible blindness. That rate of inflammation is 1 out of 4,000. That's what it's thought to be right now. So again, very rare, but you have to realize that those getting Syfovre are usually getting it in their better seeing eye, because the best candidate for Syfovre is thought to be the patient who lost vision and is legally blind in one eye due to thinning of the retina or geographic atrophy, who now wants to slow the atrophy down in the other eye. So again, it's something to take into account. I have very thorough discussions with patients before I start people on Syfovre. I have quite a few patients who are getting it and want to keep getting it. And then I have a couple patients who started getting it. Then we looked at the pictures and didn't see that it really slowed the atrophy down over 6 months, because now we've been giving it. It got approved March of 2023, so we probably started giving it in the fall. And so I do have 6 month worth of pictures on these patients, and I have stopped the shot in a couple patients who didn't really want to proceed. And then I have others who are not interested, or they want to wait for more data. So it's really across the map, but I just mention it because it is a new development in the field. Okay, my last section that I'd like to talk about before we open it up to questions is just the future of AMD treatments. There are a couple new technologies that are being studied that really promise to potentially change the fields, the way we give the shots. And again, the huge issue is the durability. So I do think we have good medications, particularly for the wet AMD, but the issue is it involves the patients coming every 4 weeks, 8 weeks, 12 weeks, 16 weeks getting shots, which is clearly a burden, especially on the elderly who rely on other people for transportation. So the first thing I'll discuss briefly is something called the PDS, or Port Delivery System. And I got a lot of questions on this when it was first approved. This is the implant that we suture into the eye, and it is a procedure that gets done in the operating room. So it's a minor surgery of the eye. It's a surgical implant, and it's since been recalled, although I'm sure it will make a comeback. But I got a lot of questions in the office like, "Hey, I hear there's this implant. I don't need to see you anymore. I don't need to get shots all the time." And the data initially was very exciting in that 80% of people were able to go 6 months without an injection. And basically, what this implant did was it carried Lucentis, which is one of the drugs I had mentioned, one of the VEGF inhibitors. And it gets placed in this implant, which then gets slowly released in the eye over time. So that sounds great, 80% getting no shots over 6 months. However, the implant was recalled for a couple reasons. The initial issue with the implant was people were getting blood in the eye, but that was addressed pretty early on. Initially, it was a 50% rate of bleeding in the eye from the implant procedure, and that's a very high rate. But then the protocol was changed a little bit, that rate went down. The second issue to arise from this PDS, or Port Delivery System implant, is the infection risk. So I mentioned that the rate of really bad infection with shots is 3 in 10,000, which is an acceptable risk. With the PDS implant, that rate is at least 3 times the injection rate of infection. And the reason being is that implant stays in your eye forever unless there's a reason to take it out. So if there's some erosion over the implant, the skin of the eye, or what we call the conjunctiva, covers that implant. So if that becomes thin with time and there's a defect, that puts the patient at risk for infection. If someone does some eye rubbing or something like that, that could cause an infection. So that led to a black box warning on the PDS, but it didn't lead to a voluntary recall by the company. What led to the recall was there were these reports of septum dislodgement, which is the actual implant itself was becoming non-functional, and you wouldn't be able to fill the medication in the office, which is what you would do subsequent to the operating room placement of the implant. Is every 6 months you would do a refill procedure in the office. However, if the septum's dislodged, you can't refill the medication. So that's when Genentech recalled the PDS, and that's still being studied and will probably come back in a slightly different form. Number two for AMD future treatments that I wanted to discuss briefly was gene therapy. So there are several I know phase 2 and 3, and maybe some phase 1 studies looking at gene therapy for wet AMD, which is pretty exciting. Basically, you would implant a gene either in the operating room under the retina, so subretinal approach, or in the office with something as simple as an injection, or an injection in what we call the suprachoroidal space, which is we do have some experience with suprachoroidal injections in the office for a different indication. So basically, it would be in the operating room or in the office, and we would inject a gene product that encodes for, at this point, either Lucentis or Eylea to be made indefinitely in the eye. So again, would be pretty exciting to just do one procedure and not have to keep injecting the patient over and over. However, this is still in a study trial. It's in clinical trials. It's not yet approved or available, but I expect in the next, couple of years, there's going to be more talk about that. Two more things I'll talk about briefly is stem cell therapy. The reason why I include it in this talk is because I got asked a lot by patients, so where are we with stem cell therapy? Still, again, in the clinical trials stage, so it's not approved. I think we're years away from stem therapy, but it is being studied as a way to replenish retinal cells, and specifically, a lot of it is targeting something called the RPE, which is a layer under the retina, to help replace tissue that's lost to geographic atrophy due to dry AMD, or progression due to the wet AMD, and of course, other retinal diseases as well. So, again, it's exciting stuff, but it's not yet available. No one in the country can offer stem cell therapy. There are some unapproved, dangerous stem cell centers that exist. I've heard cases in Florida, for instance, but this is not FDA regulated, and it is not recommended at all that you seek stem cell therapy unless it's in the context of a trial that's being very closely monitored. Last thing I'll mention is I'll often get jokingly asked, "Hey, doc, when are you going to implant my eye? Just do an eye transplant." And interestingly enough, just a few months ago, they did do a whole eye transplant at NYU. And this was interesting in a relatively young man who does not have AMD. He had a very severe injury to his face and eye, and the interesting thing is, the eye actually took, and they proved that there was blood flow within the retina, which is very exciting. However, the patient does not see at all, and I'm not even sure that the eye moves as the patient wants it to move. But again, lots of things being looked at, lots of things being studied, and so hopefully we have an exciting future ahead in the field. So. I think that's all I have. So it's 11:40.
Excellent. Thank you
Thanks.
so much, Dr.
Yeah,
Gewaily. And
thanks.
it's a very exciting presentation. And we definitely thank you as well for presenting to us on your day off. So that's
Oh,
really, really appreciated.
This is the end of our webinar recording with Dr. Gewaily. If you'd like to learn more about VisionCorps, please feel free to reach out to us by calling 717-205-4146 or emailing us at info@visioncorps.net.